So appreciate everyone joining. We're excited for this webinar, and I have the privilege of being joined by Lisa Apple, who is a physical therapist who specializes in working with patients with scoliosis. So without further ado, Lisa, take it away.
Okay, thanks, Steve. I appreciate you having me. I'm going to share my screen, so hang on just a second. Make sure we get that up there. There we go. Can everybody see that? Yeah.
Yep.
Okay. So my name is Lisa Apple, and I have my doctorate in physical therapy. And I've been practicing for about 14 years now, 10 of which pretty exclusively with patients with scoliosis. So I originally worked for Seattle Children's Hospital, and at that time, many of the surgeons kind of wanted something else to be able to tell their families and their patients besides, you know, your daughter or your son has a curve, let's wait and see. And usually the end of wait and see was surgery. And I think that was very hard for them to keep saying. And so they encouraged us to go and get certified in Schroth. And when I had that opportunity in the treatment of scoliosis, I was like, yes, I'll do it. I have spent my whole life moving. I was a professional ballet dancer before I became a physical therapist, and I have scoliosis. So I was very interested knowing how, you know, in my professional career of 15 years as a dancer, how my body felt so different on each side and how I would kind of get a cascade of injuries on one side compared to the other. So I got that opportunity to go get certified and bring that program to Seattle Children's. And I was certified through the Barcelona School of Physical Therapy. I got my C1 certification to work with adolescents, and then spent about a year treating patients, and then went back and got my certification, my C2, to work with adults as well. So I've seen people of all ages with scoliosis, and I was trained in those three-dimensional treatment principles according to Schroth. I also got a certification in the scientific evidence approach to scoliosis, which is a school out of Italy. And, you know, I find there's many ways to treat scoliosis as long as you are using curve-specific scoliosis exercises. I'm also a certified orthopedic movement specialist, so I've done lots of work in yoga, Tai Chi, Feldenkrais, and I'm certified in Pilates as well. So I had my own business called Revitalized Movement Physical Therapy, where I work with patients for about 8 years. I had that going. And oops, looks like I can't progress. Well, Steve, I might have to have you jump in.
Okay, no worries.
Let's see. All right, I'm going to stop sharing. Okay, there we go. We might have to have you pull it up. Sorry about that.
No problem at all. Let me
Yeah.
get in here. Okay, and next slide.
Yeah, go ahead to the next slide. Thank you. So most of you probably know what that definition of scoliosis is, but I bring it up because I don't feel like this one is really adequate. So this is out there in the literature as the lateral curve of the spine in an otherwise healthy child, for which a currently recognizable cause hasn't been found. And usually it's that Cobb angle that's measured, and you look at an x-ray, a posterior to anterior standing x-ray, and it tells you some things. So it tells you about where that curve starts, the upper end vertebrae, where it ends, and then of course the apex of the curve. And then you can also see some slight wedging in those vertebrae. But then go ahead and go to that next slide, Steve, and I'll show you guys the definitions that I like to point out that really align much better with the treatment of curve-specific exercise. So Oben says it's a complex 3D deformity of the spine and the trunk involving morphological as well as geometrical changes not yet well understood. So I alluded before to the morphological changes of the wedging of the vertebrae, and that's really considered in my training as sort of the pathomechanism of progression of scoliosis. So the vertebrae itself will begin to wedge, and sometimes you can even see that on an x-ray before you see the spine curve. And what happens is there is a bio-neuro-osseous theory of of scoliosis, and it's thought that one side begins to grow of the vertebrae before the other. So there's an asymmetrical pull causing the wedging, which then causes the spinal curvature. And then you have asymmetrical loading. So this is called the vicious cycle. And when we intervene as physical therapists, we are trying to interrupt that vicious cycle. So we can't interrupt the asymmetrical growth because that's, we're not quite sure why that happens. It's called idiopathic scoliosis because we don't have a reason for it yet. But there are some theories that there are hormones that, are causing one side to grow quicker than the other. And then Dr. Rigo and Greaves say it's a complex three-dimensional deformity of the spine and trunk, which appears in apparently healthy children and can progress in relation to multiple factors during any rapid period of growth or later in life. And I like to point that out because when I'm working with a patient that's a kiddo or adolescent, I like to sort of prepare them for later in life where they could see some changes that are unexpected. So for instance, after childbirth, after menopause, there are many factors that come into play throughout the lifetime. Sometimes it's an injury that can increase that curvature. So I think these two do it more justice, shall we say, than that first one of just looking at the Cobb angle. When they talk about three-dimensional deformity, they're talking about front to back, side to side, and in rotation. And when I pull up some case studies a little bit later on, you'll see what I mean by that front to back element. Yeah, good. Go ahead to that next slide. So it's typically defined in a child less than 10 years old of a Cobb angle of 10 degrees, and in a child older than 10 years old, 20 degrees. And most of the time they believe that if a curve stabilizes at 30 degrees at the time of spinal maturity, that it won't progress. And for me, personally having scoliosis, that's what happened for me. Mine stayed in the 20s. But they say that, if a curve is 50 degrees or more, it will continue to progress. And the progression is approximately 1 degree per year. And I always like to tell my patients that that statement is without any intervention. So that's without any bracing, it's without any curve specific scoliosis exercises. So just kind of, put that in the back of your mind, because I know it can be kind of frightening to think, oh, if you've got a 50-year-old that has a 50-degree curve, that's a big progression. I have seen people walk in my clinic with already 50-degree curves. I've seen 80-year-olds with 50-degree curves that didn't have surgery. So it kind of runs the gamut with people with scoliosis. Good. Yeah. So to talk a little bit about Schroth, and maybe more specifically, I should say, curve-specific physical therapy exercises. They're known as a non-surgical conservative treatment. And many of you on this webinar probably know that there are a lot of different types of curves. So you can have a large lumbar or low back curve and a smaller thoracic curve. And that will dictate kind of where the pelvis likes to go. It likes to be offset. And then the reverse can be true, where you have a larger thoracic or mid-back curve and you have a smaller lumbar curve. And that will usually send the pelvis a different way. So there are lots of different, there are 3 dimensions that we're looking at, but there's also many different curves. You can just have a single lumbar curve. And then you can also have something that even goes up into the neck called a demodifier. And that usually comes along with the larger thoracic curves. It's trying to balance out in the neck or the cervical spine with the lumbar curve. So the main principles of Schroth, and I usually say the number 1 principle of Schroth, is to elongate. And you might be able to see behind me, I have Schroth bars, they're called, or Swedish bars that you use a lot in the method of curve-specific exercise, where you elongate and you teach someone almost as if you're putting your hands on your pelvis and you're teaching them to elongate away from their pelvis. Then we have the derotation element and the deflection. So usually the deflection has to do kind of with not only the trunk, but the pelvis. A lot of times in that instance where you have the thoracic curve that's larger than the lumbar curve, that's normally seen on the right side, although you can see it on the left. But when I mentioned earlier in my own personal life, that sort of cascade of injuries, what tends to happen is you tend to bear weight more on the larger curve side. So what that means over time is that if you bear weight on the right side, you can all of a sudden start to get a collapsed ankle, you can get bunions, you can get something called genu valgus in the knee, you can get hip issues. And so when I work with patients, I like to talk to them about their entire lifespan, not just when they're right in front of me as a kiddo. Rotational angular breathing is always sort of a hard concept for people to wrap their head around, but on the concave side, so if I kind of put my hand up like this side, you usually get more of like a shortening or a collapsing of the rib cage where the ribs get tighter together. And then on the convex side, they get further apart. So rotational angular breathing is to try and expand those areas that are concave, bring breath to that area, utilize those muscles in between the ribs and where they connect to the spine in order to have that affected change on the spine. And then once you have those elements of elongation, derotation, and deflection, along with the breathing, you really want to do a lot of stabilization to correct the 3D spinal alignment. And so I'm talking with my patients all the time about certain activities that they may want to eliminate from their workout regimen, or they may want to eliminate doing too many repetitions of. For instance, doing a lot of sit-ups can actually make that curve worse because it is taking advantage of that wedge shape and causing that vertebrae to fall down against gravity. The main test for scoliosis is standing and bending forward with your hands together. And that flexion really pulls out the full extent of the curvature. So it's a test. But if you think about implementing that in your daily life, doing a bunch of sit-ups, that's not going to be great for you. So I teach people certain ways to stabilize once they have corrected that spinal alignment as much as they can. Yeah, so that's a lot to juggle. And I tell patients it feels at the beginning that they're learning a whole new way of moving. But that's so we can get them to the goal. So there's so much more to curve-specific physical therapy exercises than just reducing the Cobb angle. But yet sometimes success is sort of whittled down to that, when you're talking to surgeons and doctors. But the way that I think of the work I do is that I'm improving their body mechanics so that, and educating them enough on their specific curve so that they can go out and make movement choices that benefit their curve and don't make it worse over time. So improving their understanding of their specific curve pattern, as well as accepting that they have scoliosis. They're never going to go back completely to zero, but they may be able to reduce their curve slightly if they combine Schroth and bracing, and have a much more balanced musculature, because basically the muscles are pulling on those bones. And, the more that you kind of sink into your scoliosis, that is a flexible part that can get worse and worse when then that drives the structural part. So obviously we're trying to prevent the curve from progressing. We're trying to halt it, trying to improve the breathing to be able to oxygenate all different parts of the lungs. And then improve tolerance and endurance to other activities. And this one is not really to be dismissed, the improving posture and enhancing the cosmetic appearance, because scoliosis is more than just physical to whoever has it. It is both physical and mental, and you cannot separate those two. So most of the time, people that come to me, what really bothers them, they may not be in pain as a kiddo, but what really bothers them is how their body looks. And so, not only are we trying to obviously stop that progression, but we're trying to enhance their posture so that it's not part of that vicious cycle that keeps getting the asymmetrical loading and keeps progressing it. Reducing pain as well is something that curve-specific scoliosis can do. And, with bracing, a lot of times if you don't teach someone how to really lift up and out of the brace, they'll sink into it just as they might a crutch. So there's a certain type of brace called a Rigaud-Chenot brace that has holes so that you can actually expand those concavities with your breathing into it. So a lot of what I do is teaching people how to utilize that as well. Yeah, good. Next slide. And I show this slide just so that it brings home that scoliosis is not just a bone deformity. It is a ligament, tendon, muscle, full body change that happens. So in the picture that says obliques above it, you can see that is trying to show the oblique sling of the body, that there's a lengthening that occurs on one side and a shortening on the other. So in kind of a nutshell, a lot of the curve-specific exercises are trying to place the patient in a position in which you're elongated, derotated, and deflected, and then you can engage the muscles. So I don't know if anybody on the call has ever had a knee injury or a knee surgery, but there's a phenomenon that's called arthrogenic inhibition, or just inhibition of the quads. And part of the reason for that is that there's pain, right? But in scoliosis, there's also the idea that there's a length tension discrepancy. And so the length of the muscle is in too long a position in order to activate correctly. The same can be true for the side that's too short. It can't be activated correctly. And so in order to get it not to be inhibited anymore, then we have to get it in a more equal length tension. And you will see that in people that have scoliosis, is they'll have one side that has a lot of bulk to the muscle, and they'll have one side that's really flat. It's almost like that muscle doesn't know that you're talking to it. And it's because it's inhibited due to the length. So the second picture has the psoas on it, and that's just a very big muscle in the middle of our body that runs all the way from that low back or lumbar spine into the hip or the top of the femur. And it will change how you walk. It will change how you do stairs, anything that has to do with hip flexion. So some of the exercises that are curve specific will literally try and create symmetry and then shorten that lengthened side. Same can be true for the other side. And then you can see that in the latissimus as well, and in the quadratus lumborum. So just a few examples to really make you aware of curve-specific physical therapy is going to be very different from normal physical therapy and normal exercises. I always tell people, it can be frustrating to some, but I always tell people you'll rarely hear me say, I want 3 sets of 10. Why? Because you have to first lengthen into a position, derotate, deflect, all those things, breathe into that area, and then activate. So it's much more complicated and takes a lot of mental focus as well. Yeah, so in terms of efficacy, this is a tough one. There have been more and more studies done recently, and I highlighted this one from 2019. It had 4 randomly controlled trials, which is sort of the gold standard of research. And it did show that Schroth, or curve-specific exercises, had a significant effect in decreasing the Cobb Angle compared to non-surgical management. And what they mean by non-surgical management is just sort of any other physical therapy you might throw at it, or taping or any other modality. It can increase self-efficacy. a lot of times the worst feeling in the world is that something is happening to you and you have no control over it. Self-image, it can increase your self-image and then reduce back pain, as well as increase muscle endurance. And I'll point out a specific exercise when I get to those case studies at the end that show kind of a funny looking exercise that helps with muscle endurance. Yeah, so this example, and I think we're going to be able to play this little video. I'm not sure if you'll hear the sound or not, but basically this is an example of that curve type that has a larger lumbar curve than thoracic curve. So that lumbar curve is about 42 degrees and that thoracic curve is about 34 degrees. So let's see. And Steve, if you go on the very bottom, scroll on the very bottom, there should be kind of over towards the, yeah, there should be maybe sound.
Got it.
Do you want to pull it up?
Hold.
Sorry, would you like me to start over and put the sound
Sure.
at the top?
Yeah, sure, you can do that.
Opening up these ribs back towards the back of the room. Good. Let me see more space in between those.
Oh, I've got on mute. So I'll kind of explain when I'm tapping in her mid back there. That's what I meant by that front to back element. So sometimes people will get very flat right there in that spine. And so I'm having her lift off of that lumbar curve with a little pad under it and then expand the collapsed side and trying to get more breath into that rib cage. And so she is lying on her right side. And we have a belt around her pelvis, kind of what I was describing before when you're trying to lengthen away from that pelvis and expand the space between your vertebrae in order to derotate them. Good. Okay, I think I have one more video or case study. Yeah, so this is an example of a young man that I started working with when he was about maybe a freshman in high school in the summer. And so that picture on the far left, you can see that there's quite a bit of a waist crease there on the right side that's overdeveloped. And then both of his scapula or shoulder blades are kind of winging in different ways, and the right side is higher than the left. So with my practice, I always take pictures before from the back, the front, and two sides, and then after I take pictures because I think it's so important for visually for people to see the work that they're doing. And at its basic core, Schroth or curve specific exercises are neuroplasticity. So you're creating a real neuromuscular change where you have to repeat many, many times the corrections. In order for those to sink in. And if anybody's played any sports or any musical instruments, you know that you have to fine tune and be super specific in order to make those changes. So on the picture on the right, you can see he's a bit older. I've been working with him for a little while at this point, and he is more symmetrical in his back musculature. He's decreased that waist crease quite a bit. And then on the video, I'm doing an exercise that's known as prone on knees. And for him, his pelvis needs to be pulled off in that direction. But here he's really working on stabilization. So he has corrected as much as he possibly can that spinal alignment. And then he's going against gravity and trying to increase the endurance of his erector spinae muscles, or those muscles that run alongside the back, well, as well as many others that you can see. But yeah, he did a fantastic job. So yeah, those are the two that I had to present for you guys. And please feel free to ask me any questions. I'll do a couple key takeaways. So before we do that, so the main thing that I like to say is be an informed consumer. You know, if you feel in your gut as a parent or a person with scoliosis that you want a second opinion, get a second opinion. You know, Schroth is not right for everyone. It is a very specific type of therapy, and you do have to work hard to make it work. It's mental and physical, and sometimes it may be worse for someone to put themselves through it if they're not ready for it. I've had several patients where I have said, you know what, right now, I don't think it's right for you. You're not ready for this. Come back when you think you really want to work hard and want to work holistically. It's not a, swallow a pill and it's gone kind of thing. So that reduction or the maintenance of the Cobb angle is really not the only benefit of it, as I had on that slide earlier. And then doing bracing and Schroth together is really considered the gold standard, especially in adolescence. Yeah, thank you guys.
Great. Well, I'd encourage everyone to submit questions in the Q&A. We have a couple here. I'll read the first one. I'm 64. I know the seminar is addressing the parents of young people. I'm hoping Schroth can help me. So Lisa, your opinion, Schroth for adults in that age range?
Absolutely. So I have seen many people in their 60s, some in their 70s and 80s that have come to me, maybe because they're experiencing more pain. So I do believe that Schroth can help, and there's some evidence out there. I think more is coming all the time. Basically what I like to say is that if you spend all day sort of side bent like this, if you don't have scoliosis, you're going to have some pain later in the day. And so what Schroth is going to do, or those curve specific exercises, is teach you how to lengthen the one side, how to shorten the other side, and then how to stabilize. And it's through that stabilization that you can get some help as an older individual. You are probably never going to reduce your curve, but you can keep it where it is and prevent that 1 degree of progression that is known to occur every year if you have a curve over 50 degrees, if you do nothing. So, absolutely.
And the follow-up question there was kind of related to different schools. And we had a few questions about this via email. So there, I think, is the Schroth Clinic in Germany. There's another school out of Barcelona. Just generally, is there a preference in your mind? Does it make a difference which someone does? What are your thoughts on the different schools out there?
Yeah, I think the Schroth school from Germany and Barcelona are very intimately tied. I think sort of the same people that began that school in Germany ended up moving, or some, it was kind of like a movement to a different country, but many of the principles are the same. So I think if you can adhere to sort of the principles of elongation, derotation, rotational breathing, and then stabilization, those can be similar no matter what school you're going to. And for me, in my case, I do use a blend sometimes of like that Italian school that I was certified in and Schroth, because Schroth is really specific. And if I have a patient that just cannot quite understand that I want them to move right here, then I'll have them do just a small movement into one plane. And that's a little bit how the Italian movement works. They have a different medical system, so they're able to kind of give smaller corrections and then say, hey, go practice that for like months and then come back. Our system here in the US doesn't quite work that way. And so, if you adhere to those principles, I think you can get a benefit from any school, whether that addresses scoliosis.
Great. And I'll paraphrase the other question we got here. What other options are there outside of Schroth therapy? I'm assuming other kinds of like physical activities or kind of therapeutic modalities.
Yeah, so I love that question because I am a mover. I've been moving since I was little. I did that as a profession, as a ballet dancer. I took yoga, all that stuff. There are some people in the scoliosis world who will absolutely say yoga is terrible, right? But there are other people that that love it and have found benefit from it. And so what I try and do is teach my patients as much as I possibly can about their specific curve, things that ultimately they should not do so that they can avoid those. So for instance, in yoga, you're not going to want to twist, and those of you with scoliosis on here know that you can twist way further on one side compared to the other. You're not going to want to perpetuate that, right? You're going to want to get as much symmetry in your body. So any activity that you're given, you need to look at that with the knowledge you have about your curve. And then I feel like I, send people off with some good educational parameters that they can do anything with.
Great. All right. We have a question. Short of X-ray, are there useful tests to help differentiate rotation angles? And can you speak to perhaps massage and scoliosis, or how they can work in combination?
Yeah, so if I understood that first part, they wanted to know if there are any other tests or methods. Right. So there are a couple of methods, particularly for the rotation. There's the scoliometer, and there's some, more digital types that are maybe coming out where it can tell you about the rotation of your trunk. I always like to keep my eye on that as a therapist, because sometimes that can be an indication that, oh, it's progressing if I see that. There's another method called the formetric or DEERS, which not very many people have in the US, but they're machines that kind of don't have the radiation, but show the topographic visual of the trunk. So those types of things, can be used, but really I believe that the low dose X-ray is probably the most definitive to really show you what's going on in the spine. Yeah.
Okay.
And then I feel like there was a second part to that question. Did I miss it?
They were asking about massage as a technique.
Yeah, I think myofascial release is something that I have definitely referred my patients for. It's a little bit more of a specific type of, fascia is sort of the glue that holds us all together. It's sort of interwoven in all of our muscles and organs and everything. So I like myofascial release for it. I don't know that there have been any studies that show one way or the other. But sort of straight massage, I think that it's like anything. There can be great doctors, there can be great PTs, there can be great massage therapists, but then there can be also some that don't understand what scoliosis is and what needs to be done for that person. So really communicating well with all your practitioners, I think, is important, and getting a team approach. And that's why I love this forum so much, because I think it brings in a lot of people that have experience with it, where you can get information and you feel like you're sort of not alone out there trying to pick information from everywhere. Yeah. Okay,
we had someone submitted a question stating that their daughter is status post vertebral tethering surgery. And they're still experiencing a prominent tilt on her concave or protruding side. And she's leaning to the right side. What can they do? Is kind of this method of PT still an effective approach?
Yes, absolutely. So I see people after tethering and even after, the traditional rod surgery, because basically anything that's happening to the spine surgically is not doing anything to the ribs. And the ribs often are prominent on one side, either sticking out posteriorly or on the opposite side anteriorly. And so, therapy that's really curve specific can address that. And it is not uncommon at all, because proprioceptively, or kind of where you feel your body is in space, is really ingrained in us. We're used to maybe standing with weight more on one side. You have to be taught how to get more symmetrical. And then you have to practice and practice and practice in order to undo movement patterns that have been neurologically wired. So maybe I said this earlier, but I'll say it again, is that I feel like curve-specific physical therapy or physiotherapeutic scoliosis-specific exercise is really meant to change neuroplasticity in your brain. So change neuromuscularly your body. Yeah.
Okay. One attendee submitted that their daughter is 17, has an S curve, and is a serious ballet dancer. What things do they need to be mindful of?
Yeah, that's a great question. So, you'll be able to say these words to your daughter, she'll understand them. But like when she takes her leg behind her into an arabesque, there'll be one side where her leg will be able to go up like crazy. There'll be another side where it will be harder to go up. She needs to make those as symmetrical as possible. Yeah, and I think Schroth is great. You know, dancers and gymnasts are kind of always looking at themselves in the mirror because they're making those specific changes. And so they can do curve specific exercises well. I think also not just sinking into the movement is really important. You have to lift up, elongate, use that #1 principle of curve specific exercise. And I do say a lot of times to my patients that they learn the exercises and then they think there's no way that I can ever do this like consistently enough to make a difference. And I say, there's a reason that ballet dancers look different from weightlifters, look different from swimmers, look different from, you know, football players. There's a principle called specific adaptation to impose demand. And it is true for our bodies. What we spend time doing, we change the way our muscles pull on the bones, and we change the formation of our muscles and then our bones. So, you know, physical therapists always say form follows function. So if you're sitting in a recliner chair all day long like this, you better believe that you're going to end up looking like this. And so that's why I say it is important. It is hard work. But it has to be lots and lots of repetitions in order to make that movement pattern change.
Okay, so I'm going to combine a question we got in the chat with one via email because they're pretty similar. So how would you adapt some of these exercises to like an office or a dorm or smaller locations? Because, for example, like the bars behind you are difficult to transfer to have in those kinds of locations.
Yes, absolutely. So I have gotten really creative over the years with some of my patients because inevitably I get that question, or I get, hey, I'm going on vacation, I can't take all this equipment with me. You know, anything that you can kind of reach up and grab and do a little hang. It's a supported hang. It's not just to like give into the hang, but it's a hang with your corrections for your specific curve. So there are a lot of creative ways that you can utilize door frames as long as they're, you know, nice and sturdy. You can use some bracing mechanisms so that you can elongate your spine away from your pelvis. Also really simple stuff like I tell people all the time, you know, when we used to, you know, wait in long bank lines or at the grocery store, just start to notice, hey, is my weight more on my right foot or on my left? Can I get it more in the middle? Can I bring my pelvis right underneath me and derotate it, you know, forward because it's backwards? So becoming really aware of how you place your body, that's all about proprioception, kind of where your body is in space. Those are little things that you can like kind of take your exercises with you. Breathing, you know, you can put your hand on one side of your rib cage that is maybe a little flatter, and you can breathe into that side. I did a talk one time for a University of Washington, the prosthetics and orthotics department, and I got up and kind of showed them how I could breathe into one, and people were just like, oh my gosh, you can do that? And I'm like, yes, with practice, you can do that. You can stop the breath from going in one side and you can breathe to the other side. So little things like that, taking that with you every day instead of having to have all the equipment that is behind me.
Is this a form of therapy that can be accomplished via telemedicine, you know, over video?
You know, I do see some people over video. I usually like to see them in person a couple of times because some of it is, you noticed in my case studies, there was a lot of tapping, there was a lot of moving. Sometimes input into the physical system is important with touch, but it's not impossible. It just kind of depends on the body awareness that the patient has and then the connection they have with who they're working with. So I think it is feasible. It might take a little longer for some.
Yeah, we had a few questions that were asking essentially like, is there a way to predict how effective these kinds of exercises can be? Like, say, you know, where your child is in terms of skeletal maturity and their Cobb angle, is there any way to like predict like a degree of curvature improvement?
Interesting. I don't think there's a way to predict curve improvement, but there is a large study by Lowenstein and Carlson, and you might recognize that name, Lowenstein, from one of the first definitions that I had. And they kind of did a study that it was longitudinal, so they looked back over lots of different patients over the years, and they started with the Cobb Angle and the age that that person was. And then without any intervention, they could see the percent chance of progression. Yeah, and you can kind of plug the numbers in there. But in terms of efficacy, I will say that efficacy with curve specific exercises and even bracing is a very difficult question to answer and study. And the reason for that is adherence is the word they use in the bracing world, and then compliance is the word that they use in the physical therapy world. So you guys probably know, you might start off with all the best intentions, but all of a sudden you've got your physical therapy appointment that next week and you're like, oh, I haven't done my exercises. So, you really have to be all in with this. And a lot of times it does take a family, it does take a support system in order to help along the way. And the unfortunate part of it happening, or curves coming out when someone is going through puberty, is that, kids are trying to be independent, right? And they don't want their parents telling them they have to do A, B, and C. Sometimes I've had so many people say, I don't want my mom or dad watching me when I do the exercises. And I say, okay, now this means you have to take personal responsibility for it. So it is a multifactorial issue. It's a tough one. Yeah.
Someone's asking, do they even, I just addressed this a little bit. Are there any known causes of scoliosis in adolescents? And attendee gave the example of like teaching, is it potentially due to lack of teaching youth about posture or body awareness, like, no slouching or hunching in front of screens?
Right. No, and I have answered that question from many parents who have a certain amount of guilt of like, hey, I didn't notice this in my kiddo, and then all of a sudden they had a big curve, and what happened? Did I do something wrong? Did I make them practice piano too much? Those kind of things. And right now we don't know of any known causes for it. There are some theories out there that it's a hormonal component. There's a genetic component as well. So, a lot of times I will see families that have it in them. Now, in terms of not doing certain things, I do think there's a functional, like once it's happened and the wedging happens in the spine, I think you can avoid certain movements that will help not progress it. But I don't think there's anything that actually causes that wedging that we know of right now.
What's the best way to find a Schroth therapist or someone who specializes in scoliosis like yourself? Yeah,
I would go to the BSPTS website and find them. And I don't know if the National Scoliosis, that we may have a resource like that. You probably could answer that more than me, Steve.
I could probably dig that up because I think I used that to find you.
Yeah, I think that's a great, so many people are looking because there are not very many of us that are certified in the US, because the certification takes a lot of dedication and work, just like the method itself takes a lot of dedication and work. Essentially, if you get that first certification and you work a year with adolescents, if you don't go back and return to get your second and now third certification, then you will lose your certification altogether. So they've kind of changed a little bit, like the program itself. So it may be under different terminology, but yeah, it takes a lot. So I would say BSPTS website.
Great. And I did respond to someone with that link that should be visible to everyone, but we'll follow up via email afterwards with that information too, if anyone wants. Is this form of physical therapy applicable to people with like muscular dystrophy or other kinds of conditions?
Not muscular dystrophy. That would probably be, it would be a similar kind of theory, and that you would have to repeat often the exercises to support the posture, but different in that this is curve specific. There's one other point I was going to make about that. Oh, for Sherman's kyphosis, Schroth physical therapy can be used for that, and that's sort of that front to back curve that tends to round people. So it can be used for Sherman's kyphosis and scoliosis.
Great. Someone is asking, is the Rigo Cheneau brace better than the Boston brace?
Yeah, that's a tough question. I would say that the Rigo Cheneau brace, I think there have been some changes to the Boston brace that make it more three-dimensional. I think any brace is better than no brace when you're talking about a kid that still is not at skeletal maturity, and especially in combination with exercises. I personally like the Rigo Cheneau brace the best because it mirrors and mimics the curve specific approach. So it's got holes where you need room to breathe. It has pressure points where it derotates you and elongates you. So that is my personal preference, but I never, I don't turn anyone away that has a Boston. I work with them because I think they're, it's just the gold standard to get into a brace and do curve specific exercises.
Are other forms of exercise beneficial for scoliosis, like Pilates?
They can be. I think in terms of stabilization, it has maybe a leg up on how people usually look at yoga versus scoliosis. Yoga, a lot of times you can kind of sink into the pose and let it take you. It's kind of all about your approach and all about the teacher and how aware they are of what your curve is doing. There's a lot of flexion in Pilates, and so you have to be careful about that. When I incorporate that technique, when I work with people with scoliosis, I tell them, don't curl up past your curve. If you don't have a curve in your neck, yeah, you can at least tuck your chin and engage your abdominal muscles, but I'd much rather give somebody their specific corrections to make symmetrical their back and their spine, and then have them do some sort of plank or something that's a little bit in more of a neutral position for their back. Yeah.
There are a few questions from people who had children who had, completed puberty or they had achieved skeletal maturity, and just want to know if this was still an appropriate form of therapy once they treated or once they pass the intervention stage.
Absolutely, because there's both the functional part of scoliosis and the structural. So structural, those are changes that are morphological that have taken place in the spine. You can't really undo those so much, maybe a little bit. But if you don't sort of hang on and maintain enough strength to support your skeletal system, then the functional will kind of take over and drag you into that curve pattern. So it absolutely can help. And, I've even had people that, unfortunately, scoliosis is very gray. We don't know why some curves progress and why others stabilize. We just don't. I wish we had those answers, but we don't. And so I had a patient that, I worked with him and he was doing great. And he said to me, I feel like I can move my body so much better. I have more control. But then he started drifting, to a higher curvature, and, we don't know why. And so he ended up getting surgery, but even after surgery, he came back to me and he said, I still have this and I still, this part of my body. And so we still work together. So I think it can benefit, kind of no matter where you are in the process.
Is physical therapy typically prescribed post-surgery in these cases? Is that a normal course of care?
Unfortunately, it is not the norm. I think some surgeons do. I think some surgeons are kind of not as likely to prescribe it because they're worried that they're not going to get that specific treatment that they need. And so they shy away from it. You know, a lot of times you'll hear, oh, just 12 weeks of modified, you know, don't do much and then you're good to go with any activity you want. And as a physical therapist, that just blows my mind when I hear that from patients, because with anything, we know, the example I gave before about knee pain, when you have pain anywhere in the body, there's a normal activity of inhibition of muscle activity. So why wouldn't you want someone to go and start using their muscles? It's like use it or lose it. In my current role right now, I work with a lot of neuro rehab products. And I just encountered someone who had a stroke, and he said in his brain, he was like, I have to kind of try and keep moving. I have to, and you have to send that signal from your brain to your muscles and from the muscles back to the brain that they're working. So any kind of surgery is another insult injury to the body that needs to be overcome by movement. And when it's scoliosis, you know, it should be obviously, specific to what that person needs, not just kind of willy-nilly go do anything. Yeah.
All right. Short of seeing a specialist, how can someone determine curve specific exercises for themselves?
Yeah, I think that's really tough because you need to know what your curve is. You know, through the x-ray, you need to understand that. I think there's more out there. But it's kind of like, and I hate to use this example because we as people are not machines, but it's kind of maybe like a computer is a good example. If something's wrong with your computer and you are not an expert in a computer, then why would you ever try and fix it? You know, it's sort of the same for scoliosis. If it were just that simple of like, hey, do 10 side planks, then you know, we wouldn't have any scoliosis in the world. Yeah.
Right. I think that wraps up the questions that we had. Did you want to have any final comments, any thoughts that cropped up while we were going through the session?
You know, I think I'm just so glad to see so many people on here, because I know from, you know, experience with my patients that it is a journey to find information. And I know that a lot of people really want, you know, just to do the best for either themselves or their child, you know, whoever has scoliosis. So I'm glad to see so many people are open to, you know, learning about more conservative ways to treat scoliosis. And I just encourage you guys to do your research. There is a free scoliosis journal site that you can go on and read tons of articles about it, about scoliosis and kind of what's happening, the latest surgical techniques, as well as the latest conservative treatments. But I just encourage you to just be a very well-informed consumer of treatment.
That's great. Well, appreciate everyone joining us today. And thank you so much, Lisa, for this wonderful session.
Thank you, Steve. I appreciate it.